Our next speaker is Terie Dreussi-Smith. She's from Taylor, South Carolina. She presents close to 100 Bridges Out of Poverty seminars annually. She also co-authored Bridges Out of Poverty Strategies for Professionals and Communities. Terie assisted communities to embed Bridges Out of Poverty concepts in redesigning policies and services for families and youth in generational poverty. She increasingly is spending more consulting time training with Bridges into Health. Dreussi-Smith also co-authored a book for the health sector, having many years of experience implementing the public health model to promote health and wellness initiatives in her role as the prevention specialist for addictions, also the program manager and community consultant. Ladies and gentlemen, please welcome Terie Dreussi-Smith.
Thank you. Good morning. It's good to be here. Well, greetings from Greenville, South Carolina, where everyone is from Michigan. And I'm just as bad because I'm from Ohio. So it's a pleasure to be in Indianapolis. I have a niece that lives here, and I call it the Rome of the Midwest. So I do have a few notes here. I always tell people who are new presenters, you only need notes for the first 15 minutes. So since I only have 15 minutes, I have to have a few notes. I think that what we're going to be talking about for the next few minutes is how economic class intersects with race, gender, and all the other parts of our experience, and how we use our environments and how we use our individual assets, strengths, and individual risk factors, how the two combine. Because when we build our strategies, we often have, and if I could have the slide move, I'm used to having it myself. Is anybody going to move the slides for me? I do have a clicker? Well, here goes 2 minutes right there. Okay, I'm sorry. No one gave me the in-service on the clicker. So what we have here is a mental model of poverty. Now, we paid some folks who were experts to form this model for us, and those are people in poverty who go through our Getting Ahead in a just getting by world curriculum. And one of the first things that's done is a circle is drawn, and this group of folks in poverty says, okay, what is poverty like in our community? You know, our environments, the population health research show, have a tremendous impact on us and have an impact on our health behaviors. Have you ever tried to diet? Have you ever tried to stop smoking, lose weight, exercise more, maybe stop drinking? You'll notice that in some environments you do better than in others, right? It depends also on your support system, which may be an individual resource, may also be part of that circle of the environment. What we offer are things that you probably know and things that are research-based, but we offer you tools and models and a common language so that, you know, everybody can have what's the definitions, the models, and it gives you a little bit more smooth sailing when you begin your initiatives and how you design programs. I want to talk to you a little bit about the relationship between the environment and how does that relate to relationships of mutual respect. So I figure there's about 14 environments that I belong to, or groups that I belong to, and you probably do as well. So there's groups in terms of race. That experience is very diverse. Ethnicity, gender, sexual orientation, you know, whether or not you're a parent, your education level. All of these are different environments that you move in and out of. And each one has its own set of hidden rules. Hidden rules are unspoken cues and habits of a group. And here's how inner rules play out when it comes to health. The word is marginalization. What we know that any group that is marginalized by their community tends to have health inequities. How do we marginalize one another? Is that better? You can hear me better? So here's how this happens. So let's just take generations, for example. Ask a 14-year-old what a card catalog is. Yeah. And how do you do when your computer crashes? Are you able to fix it? Or do you call a 4-year-old over and say, honey, can you help me with this? I don't know if you've noticed this about age, but there are different environments that you move through as you age. When you're 5 years old, you can go up to somebody and go, you're fat, and you can probably get away with it. You do that when you're 6, 7, 8, you're going to get more of a backfire from that, right? When you're 80, you can start saying that stuff again. That's one thing to look forward to. Be healthy and live long, right? I got on a plane in West Palm Beach. Now, I was going from West Palm to New York. There were a lot of New Yorkers on the plane. I don't know if you know this, but regions of the country have their own hidden rules. As somebody who moved from the north to the south, I thought bless your heart was always a kind thing. It isn't. It can mean you poor, stupid, pitiful thing. I thought it always meant a good thing. I get on the plane, there's this 80-year-old from New York sitting there behind me. I'm putting my stuff up. She goes, "This plane is older than I am." I thought, you know, if that's true, that can't be good, but I didn't want to say anything. I taught to respect people, especially those that are older. And she says, "You know, this is the smallest plane I've ever been on in my life. I don't like these small planes." I said, "Why not?" She goes, "They go down," which is true. She's got the statistics right. She said, "You should see how small the bathroom is. You're not going to fit in that bathroom." Okay. So what happens is we have our hidden rules, and these are unspoken cues and habits of an environment. And when somebody breaks a hidden rule, typically what we do is we don't say, "Hey man, you broke my hidden rule. Let's talk about it." Or when you see somebody break a hidden rule, do you go over to them and go, "Look, next time you ask the boss for a professional day, you might want to make sure she has her third cup of coffee." You know? What we do is nothing. It's a dead silence, and somebody will give you the look. Have you ever been there? Have you ever broken a hidden rule? Would you turn to your neighbor and give them the look that somebody gives when a hidden rule is broken? Please do it. Don't smile at them. Give them the look. Remind them what that feels like. Right? Some of you are very good at that. Do you think that people who are marginalized get the look when they go for health services? You know, how does patient engagement impact the bottom line of cost and health outcomes? If we're getting the look, we don't feel like we belong. See, all of our experiences and all of our hidden rules are about belonging. And when we get the look, we feel like we don't belong. Why don't we share hidden rules with one another so everyone can belong? That would help a lot in terms of reducing that marginalization that we have in our society. Now, I have to tell you one more thing about regions of the country having hidden rules. I was in Charleston, South Carolina, and I said, "Please turn to one another and give one another the look that is given when people break hidden rules." And someone looked at me and said, "We would never give the look." That's just rude. And someone else said, "Yes, but Mamie, we would talk about her later." And that's when I began to realize I had to learn the hidden rules, right? And so, here we go. Let's talk more. This is our model for your individual strengths. As you can see, right in the palm of the hand is social support and social capital. The work of Dr. Michael Marmot, who is sort of the guru of population health research, the father of population health research, if you would, says that health has a strong relation to our social capital. Whether we have bonding social capital, which are people that help us get by, or bridging social capital, people who help us get ahead. Our strong social cohesion in our community also is a protective factor for health. That means that you don't have this group in this corner of town, this group in this corner of town, the folks in poverty basically in one corner of town, and not have a socially cohesive community. How do we relate to people who are in the other groups? We think this doesn't matter. Yeah, we may have great social capital within those groups, but how do we relate to one another? It's about belonging to the community. If you and I feel like we don't belong to the community, we're going to have health disparities and poor health outcomes. So I want to go and talk a little bit about the statistics. Of all of the factors studied in Indiana, the #1 predictor of birth outcomes was the number of prenatal visits. And as you can see, those visits for patients on Medicare were greatly reduced. And so before I came out here, I asked this question. Does Medicare limit the number of prenatal visits? What do you think the answer is? The answer is no. So there's another factor. So basically, if I'm on Medicaid, sorry, I did that back there too. If I'm on Medicaid, I tend not to have as many prenatal visits, right? But Medicaid doesn't limit the number of prenatal visits. So what else is happening? Could it be that when I'm in poverty, it's a now world, and I've put health on the back burner? I've met a pediatrician once. He said, I understand if people don't have transportation, but I'm working with a mother. Her son has a condition he needs to come in regularly. She has a Mercedes. This is a Medicaid Mercedes. He said, there is no reason that she can't be here. I said to him, it's not just about the external resources. It's about living in poverty for 3 generations. Do I really believe I have future story? Do I see that? Maybe lately I have a little bit more financial assets, but does that mean that my perspective has changed just like that? What is the definition of poverty? Well, some people think, and many academics think, it's a number, it's financial assets. Most of us that work day by day with these issues of health and with those who are in poverty and not in poverty know you can change somebody's income, but doesn't necessarily change their perspective. My dad grew up poor. He had a hidden rule. It was dentists are for rich people. When he was 55, he had a union job in Canton, Ohio. He had dental insurance. He pulled his teeth out with a pair of pliers because that's what he knew. Dentists was for rich people. And even though he had financial stability, and he had 2 out of the 4 great American experiences. He had a house and a car that he owned. We didn't have the boat and the camper. That's the other 2. That's how you know where you are in the world. So what I'm saying to you is this. How people think is part of the experience. And just because the financial situation gets changed doesn't necessarily mean the resources have changed in every way. Our definition of poverty is the extent to which we do without resources. And financial resources are one of them. If you look at the number of pregnant women on Medicaid who smoked, it was higher than those who were not on Medicaid. We had someone go through our Getting Ahead group. She had her 8 steps that she created for building a sustainable life for herself. I thought number 1 should be that she quit smoking because she couldn't pay her rent. And she's spending like $300 a month on cigarettes, etc. So it seemed to make sense to me. You could, stop a lot of the chaos if you had more rent money, right? Number 1 for her was get out of bed every morning. See, most of us would not start there when we begin the plan, would we? That was a migraine problem. What she had was a health problem. Number 4 on her list, get her 2-year degree. And number 8 was to quit smoking. 2 years later, she had finished her degree, and she had the patch on. And I had to say to her, I got to tell you something. As a facilitator, I wasn't allowed to tell you what to do with your plan. But it seems to me that number 1 should have been quit smoking. She said, you know what, I could never have done 1 through 7 if I hadn't been smoking. See, sometimes we have to accept that voice, that perspective that comes out of that experience. Even though we know the statistics, someone has to do it in their own way. Look at the percentage of adults who reported excellent or very good health by income and race. As you can see, we have disparities based on race. But I also want to point out something else to you. We also have the economic class disparities intersecting with race and ethnicity here. How many of you are proud that you have a culturally diverse decision-making table? And many times we have various races, genders, sexual orientation, but what we're missing is economic diversity at that table. And why is that? Because if you get the middle class who loves the table and usually runs it, our view is everything is run from the middle class perspective. That it is the dominant economic class in terms of how we design things in our communities. If you get middle class folks with folks in poverty and folks in wealth who are on the board at the same table, we will break relationship without even knowing it almost instantly. That's why we can't be blindsided by the environments of economic class. So let me just show you. This is the environment of poverty. Those explosions represent when one thing happens, I can't stop bad things from happening. One crisis just cascades into another because the resources are tentative. It's called the now tyranny of the moment. That condition, according to the population of that environment, pushes stress. If you have lower hierarchy, low social capital, low social coherence, tyranny of the moment, you are susceptible, more vulnerable to disease. You are more vulnerable to having a compromised immune system. You're more vulnerable to having adverse childhood experiences. Here's our work about how do we analyze this so that we have a way to build relationships of mutual respect at that patient engagement level that are creative, that's innovative. And how do we work together with systems and communities and all across the board so that eventually policy will change. Here's the middle class environment. It's very future story driven. People here have to take yoga to remember there is a moment. Everybody here loves to plan. All of our organizations love to plan. Just substitute the word outcomes for achievement up here and you will have your organization. Everything is designed from this perspective, all the evaluation, the research, the policy. Isn't it interesting that people in poverty who have the inequities are really not about the outcome, but about the relationship? We need to change environments by reducing poverty. How do we do that? Well, there are Bridges communities in your state that do that. One of them is South Bend, one of them is Martinsville. There's also another initiative here called Circles. Circles of Supports, the Circles Initiative that builds social capital for individuals in poverty. This is where the answer is, a way to analyze what is happening with economic class as well as race and ethnicity, and having a system that advocates for policy change, but doesn't wait for it. It does great things now. What you do for me, you do to me. We need everybody at the table, including every economic class. This might be a way for you to get to there. Thank you for listening to me.
Okay.
Hey, I didn't use my notes. maybe I should have.
Once again, a big hand for Terie.
Thank you.
Feel bad because after my opening monologue, I went backstage and I said, "How'd I do?" And she said, "Bless your heart."
Not.
Then she gave me that look. Are we going to do questions? Or do some questions right now? By the way, just a real quick reminder, this is actually some breaking news. Dr. Adams' sock game is strong. If you can't see Dr. Adams' socks, he is, can we look at those? Those are very nice.
Those are Italian socks, I know that.
I have sock envy, my friend. All right, so are we going to a few questions?
Yes.
Okay,
We're
so we have just a few questions because Terie went over on her time, surprisingly. Just like 2 questions right now, if you guys don't mind.
Okay. Well, we're going to have a conversation, and I want to encourage you all to think of questions because we're going to have a question and answer from the audience later. But one of the things I wanted to ask you is, how is the stress of living in poverty contributing to mental health concerns? And particularly when we talk about infant mortality, one of the things that I think we aren't talking about enough is neonatal abstinence syndrome, and what are the factors leading into that?
Well, the one thing that I've seen lately, first of all, I want to make a comment that population health research 10 years ago was not really accepted by the individual health medicine and clinical health. And now you begin to see it's widely accepted. Before it was like psychobabble. You know, that has nothing to do with what I do as a physician or a nurse. But now you're beginning to see that. And what I see is the Center for Disease Control ACE survey, which is the Adverse Childhood Experience Survey. There are 10 of those adverse experiences, and poverty makes us more vulnerable to those. So if I have a number of those happening, it could be death of a parent, it could be living in an unsafe environment, and so forth. If I have multiple factors, these tend to show up in terms of mental health issues and I may not have gotten my neural pathways built from birth to 3, because actually the Harvard School of Child Development says you can teach a parent how to be responsive and use language to build neural pathways, but poverty itself, the stress of poverty at that early age, will zap those neural pathways as they're being built. So obviously, we don't know as much about this, but there's research that's coming that shows that how the brain is formed during those early years is going to have an impact.
And didn't the ACE survey show that people who had one or more adverse childhood experiences were more likely to continue to make bad choices? So a lot of times we say it's your fault. Yeah, but is it really their fault? Are they doomed to continue to make bad choices because of the lifetime that they've lived of trauma and adverse experiences?
And I think we don't intervene soon enough. So if we have increased risk from birth to 5, we're going to see that throughout someone's life. And when do we intervene with that? When does the mental health come? We also see people who have fibromyalgia, other autoimmune disorders at an early age. Migraines, these are also associated with the adverse childhood experiences. So it tends to affect all parts of the whole body,
so
not
trauma-informed
just physical.
care is really important
Yes.
at a very young age, and no matter what you're talking to the individual about.
Yes.
One more question that I just have to ask, because I love that you brought up the Medicaid Mercedes, the Obama phone. There are people in this room who I've talked to who continue to say, well, why are we helping these people? They aren't willing to help themselves. But I also feel strongly that we tend to talk to each other and not talk to the people who actually need to change policies. How do we make the point that you just made to all of us, to policymakers and to other citizens, that there's deeply ingrained poverty that's not necessarily related to the car that you drive or the cell phone that you have?
Well, it is deep. Well, if you look at the mental model of poverty, which is no longer up there, entertainment shows up on the pie. And entertainment and poverty is a big stress release, and it also helps me to, as one woman said, I thought that me and the kids need to be middle class for a while. It will show up. And I had a caseworker in Toledo say, if a woman has those fingernails, the acrylic nails, I'm not giving her a food voucher. What I'm saying to you is, we get triggered in the middle class environment by the entertainment of folks in poverty. And even if you're just talking about it behind closed doors, I call that the constant drip, drip, drip of disdain for individuals in poverty. And that will show up in our eyebrows. You know, many times I ask people, the healthcare professionals that I'm presenting for, do you think that your child's teacher, how your child's teacher views your child is going to have an impact on their grades? And they go, absolutely. I said, is it true of how we view our patient will have an impact on that health outcome? And everyone just kind of like, we're not so sure because this is science. But the science really is, how do we engage one another, and how early can we engage one another? So what I'm saying is this, is stop giving the look and start talking about hidden rules. The thing is, we think that more caseworkers and more financial literacy is the answer. But what really is the answer is everyone at the table having an opportunity to look at their own hidden rules and the lens they use, and how do we interact with one another.
And I love what you said about everyone at the table, because a lot of you know I'm still a practicing physician. And so when we're having the docs at the table, you've got the top 1% of wage earners sitting around trying to decide how to provide care to everyone out there. And in the public health community, again, as you mentioned, you've got the middle class folks in there coming up with middle class solutions and not even realizing the barriers to care that exist for everyone out there. That was just wonderful, and gosh, we could talk with you all morning, Terie, but unfortunately we've got to move on to the other speakers. But be thinking about your questions so that you can ask Terie during the question and answer session, and thank you very much.
Thank you. Give Dr. Adams a copy of Bridges for Health and Healthcare, and if this was Ellen or Oprah, each one of you would be getting one. But this is the public sector, so
well,
thank you.
And certainly we'll try to make sure we'll make sure everyone gets the info for this book, because I think it's so important that we get that message out that Terie was trying to relay. And I'm going to read this on the plane. I'm hopping on a plane when I leave here, and if anyone wants to borrow it from me afterwards, you're welcome to. Thank you, Terie.
Thank you, Dr.